pupilloplasty, which is one of the difficult procedures and difficult steps in the different surgeries. But in this presentation, I will show it as a refractive solution for some patients. And I will share my experience of the pupilloplasty by the single pass 4-throw pupilloplasty technique in a phakic eye, which is in a phakic eye, where the crystalline lens is still in, which makes this procedure so difficult, and so I have to be with the ultimate precautions. Actually, I'm honored to be the first one to report about pupilloplasty in phakic eye, while Dr. Mahbal Sadef and the co-authors published a paper how to do pupilloplasty in phakic eye by using the ICL as a protective glide to the crystalline lens, but I have done it without any protection. This patient, a 35 years old male, came to me 3 months after repaired ruptured glue. As you see in this picture with the drawn down pupil, the pupil in the upper photo is dilated in the preoperative preparation, but the actual pupil is that in the below photo, where you will find that the pupil is drawn down to come just in front of the scar of the repaired corneal wound. And you can imagine how the vision is interrupted with this scar. The repaired ruptured glue was 6 months ago with inferior transverse corneal wound scar from 8 to 4 o'clock. The unaided visual acuity actually was hand motion with the normal pupil just in front of this scar. But the best corrective visual acuity with -8 cylinder horrible amount of cylinder, but just count with finger 50 centimeters. The scar is very close to the center of the drawn down pupil. Let's go to the video. The video actually was published on the Zilla Academy YouTube channel, which is my YouTube channel. So the aim of this surgery to avoid the keratoplasty in such patients where there is some solution which is simpler and easier and less costly than the keratoplasty. Because the center of the pupil was clear, as you see, but the scar is interrupting the visual axis with the drawn down pupil. So I plan to grasp the pupil up with the reformation of the pupil to be like that of the regular one, rounded and central. So I'm going to enter with the straight needle of the tin of Prolene suture. Very carefully, you have to weigh and to control your hand, and the pass of your hand should be meticulous and should pay your attention not to touch the anterior capsule of the lens, otherwise you will get cataract. And I passed from the right side to the left side, and now I'm trying to get the needle with this microforceps to avoid harvesting or including any tissue from the cornea when the needle gets out. I have to confess that it was a difficult step to avoid touching of the lens, but it will be easy if you control the grab and get the enough space, which is formed by the viscoelastic all the time. As you see now, I'm deepening the antechamber and inflating or lifting the iris up by the viscoelastic to be away from the lens all the time. Then I will enter to grasp within the other part of the thread, keeping this peripheral end still out on the other side to make a U-shaped letter of the thread with 2 edges on each side. Then I cut the part of the needle to get a free one, and then I will count 4 turns. You have to enter in this circle 4 times, and you have to be sure. If you won't be sure about the 4 turns, you can add more, 1 or 2 to be sure. Because if there are 3 counts, there won't be a good nut at the end. Yeah, I'm trying now. And avoid washing with the sealant frequently in this technique, because this round will be masked by the sealant. This is the second turn. Yes. And keep your eye on both sides. Otherwise, the other side may be slapped, may be displaced and slip to the other side to be inside the antechamber. Now, it's the 4th, but I was not sure about the 4 turns, so I added 1. Now I'm ready to grasp both ends to find that both sides of the torn or injured iris coming together, coming closer to each other, starting to form the pupil, which you will find that the pupil is going to ramp up again, to go up again. Then I will count the free ends. And I preferred on that time, in this case, to do another pass to make the both ends closer, and for the pupil to be secure. 1, and to avoid the presence of double pupil. Yeah, count with me the turns. You'll find them 4 short turns, and then stretch to approximate the ends of the iris, trying to make it like the normal one, and close this space. The last one at the bottom of the antechamber, as you see, I didn't prefer to do, because I will yield pressure and stretch on the iris, which may make a real dialysis, and at the same time I was assured about it because it's masked by the scar, so there is no worry about the double pupil. Now the hydroid section, and look here at the pupil, you'll find it almost like normal one. So I will go to the post-operative results and report. This is before, but this is the dilated one, and this is after with a mobile capture. So the aim of surgery is not only the cosmetic reason, but also physiological and refractive goals. The unaided in this patient, remember, it was hand motion. Now the patient unaided could see 636. And the best corrected visual acuity of 618 could be achieved with only minus 2.5 cylinder. It was -8 or -9 cylinder. Now, because it's more centralized, I could correct this patient with just minus 2.5 cylinder to see 618, and he's very happy. And we could avoid the pupilloplasty in such patient. And thank you so much.